So the next speaker is Chris Fokke, who is the CCIO at Hampshire Hospitals NHS Foundation Trust, which is a relatively new trust. So I always have to find out, yeah, but what are the names of the hospitals underneath it? So I found out that it was Basingstoke,
Winchester,
Handover, and Winchester. Yes. Okay. So Chris, over to you.
Thanks. So I've been asked to talk to you in regards to leadership and collaboration. So my talk is very much from a practical level. So 3-4 years ago, the trust went on to an ambitious program in regards to they wanted to develop their own in-house EPR. So basically, in my role as a CCIO in that trust, and again, as I was saying, it's a multi-sited area. I've got a clinical background. I'm a nurse. I'm a registered nurse, and a lot of my function is to basically gather all the stories and gather all the requirements across all the areas within our trust. And so what I'm going to share is sort of like, okay, this is how I work on a practical level. This is what we're doing. And as I was cued by John in regards to, okay, I'll also add in regards to things that may not have gone as well, or if I did this again, I might do it differently. So I'll try and get that in as well. These are the key bits that I want to really address in regards to, okay, from a personal perspective, how do you improve your performance as a CCIO? How do you sort of like improve team clinical performance? How do you change organizational culture? I'm sure we've all been part of rolling out systems or new ways of working, and actually it doesn't get embedded. So how do we facilitate and change that? And also, how do we make the systems actually fit the clinical function rather than the other way around? Normally we have sort of like clinical function, and then let's shoehorn this into the systems, but how can we do it the other way around? And what are the opportunities in regards to collaboration? So how can you actually look a bit more out of the box and seek out opportunities as they happen? So from a personal perspective, so and I'm sure you can identify with this quite well in regards to, as a CCIO, the capacity is unrelenting in regards to the workload just will be up and up and up, because people want to have more systems that work for them within their clinical practice. There are more demands on the corporates in regards to, okay, we need to get better business intelligence, better health informatics, we need to engage with others. And how do you keep track of that, and how do you keep that within a normal capacity as a CCIO? So I think it's very important to think about things like coaching in regards to reflective practice, and also how am I doing? How am I doing in the organisation, and how am I doing in my role? So I've got this. I'm very keen on self-coaching, for instance. So I'm tapped into a web-based application called Alchemy for Managers, whereby you can actually pick out little modules in regards to, okay, I'm struggling at the moment in regards to negotiation, and actually it will then do a small session in regards to negotiation. You can do some exercises in regards to actually building up your skills. It's an illustration. I'm not saying that, okay, this will work for everyone, but it's definitely something that would work, that works for me, and I've been using it now for years. But I would definitely advocate things like peer coaching, which I do as well. In regards to, I have senior clinicians who've been in the role, maybe even pre-merger, because we merged 18 months ago. So I've got people who've been in similar roles in the organisation, and I bounce off ideas in regards to, okay, what do you think we should do next, and what do you think that the CCI role should push forward? Visibility is absolutely key. That's the driver I got from the CEO and the executive, and the fact that the reason why it works in our organisation is people know I'm the EPR man. I'm around. I'm on the ward rounds. I'm in the clinical areas. I'm in clinics. And again, you need to look at it in context in regards to the first bullet point, in regards to, well, what's your capacity? And this is where, sort of like from our point of view, I'm based in IT. So I'm not associated in a ward, I'm based in IT, but I have the freedom and the empowerment to actually start to self-motivate in regards to, well, what are the components where I need to be in certain areas. So for instance, right now, this very moment, I'm doing quite a lot in regards to the ED, front of house, and the CCG and the GP interfaces, for instance. That's a big push that we're working on now. Lastly, it's the engagement, the clinical engagement. And in some ways, as I said, with the visibility, it's nice if you're around, people will automatically come to you and say, okay, well, these are the things that work for us, and this is what we would like to push up the agenda in regards to health informatics. But there's also the structured part. So every fortnight, I meet up with all the junior doctors, and I have my session, whatever that might be. And what I tend to do is I tend to go through the key, I suppose, system issues that I've been made aware of, and then go through that with the juniors and say, okay, so this is how your systems are working at the moment. I hear from you that this works and this doesn't work. So what would be the golden standards, and where do we need to go in regards to making it work? You get a lot of rhetoric, but at the same time, you also get a lot of the front line. Well, actually, in my AAU, when I'm a junior doctor in a bank holiday, the thing that really makes my life help is, and that's the part that you actually want to capture, because that's, and as I said, that's the story that I need to capture to get into the development stream. I have a lot of support from the clinical function, from the nurses, the doctors, and the AHPs, and I think, again, it goes without saying, it's because I'm a clinician myself. And so hence I end up as a gatekeeper of the system development. So I'm basically the sort of like spearhead person in regards to the EPR development. I have a group that I meet with every 6 weeks, which consists of highly senior executive or consultants, AHPs, nurses and doctors, but it also consists of very junior hands-on people who literally will do the direct care at the front line. And we don't have a hierarchical sort of like system. And what we do is we go through our development phases and we recheck in regards to, is our priority still the way that it should be. In regards to the team and the clinical performance, one of the things that I've found in the last 2-3 years is the fact that I've assumed that everyone knows their business processes. So when you go into a multidisciplinary team, they exactly know what to do. And all you have to do is just say, okay, tell me what systems you want, we'll do that, and off you go. But what I've been aware of that that's not always the case, and there's quite a lot of people assuming that some people pick up a part of a process and others think the same in regards to someone else is picking up the process. So I spend quite a lot of time actually articulating what is your current process, so what do you want to do in the future, so what's the utopia, let's process map that out, but also what are you doing right now, and where are the opportunities where we can actually make the clinical systems then automate some of the processes that are a real pain. So one example, and you'll see it in a minute, is for instance if you look at the handover. So how do you do an electronic handover system for 2,500 clinical people from different disciplines, different headings in their head in regards to what's really key that they need to hand over to the next person. And that's a good example in regards to process mapping, that actually when you start to think about it with all of them, we actually came up with quite very few. I think there is 5 or 6 headings that everyone can work with. As a CCIO, I need to understand all the clinical teams, their processes. I mentioned that before, and so I spend a lot of time roaming around, and I think that's really good for me to be around, and also to get that rich information. because quite often it's an unstructured methodology where you actually pick up these stories. This is a classic example in regards to a process mapping exercise. I'm sure you've done these yourself. This is one I did last week, working with GPs, looking at, okay, so what you'd like to see is that we send off a real-time alerting message to your system to say that the patient has been admitted in AAU. That's great, we can do that, but actually how are you going to change your practice in regards to making that real, understandable, and that something actually happens to that? So for instance, what you see here is that, okay, automatically if someone puts the patient onto EPR or into the PAS, it triggers an electronic message, it gets picked up via NHS mail in the GP practice, and there are people assigned who will then triage that to say, okay, this person is known by the intermediate care staff. We'll phone up the hospital, AAU coordinator, to say, make sure that this person actually is well known in the community teams, and you could actually avoid an admission if you're smart. We all knew already that that was good practice, but to actually do it was much more challenging. So improving and changing the organisation's culture. I think you have to, as a CCIO, you have to have a lot of self-belief, and I actually think that the most important part here is that you have to be very passionate and tenacious. So when I started the EPR rollout or the development, I heard lots of people say, over my dead body. We know what we're doing, we like it, it works, we're not going to change. And you just have to keep at it and keep at it and keep at it and not give up. I can't overstate enough in regards to it's absolutely key that you have the support of your executive team. So our medical director, from time to time, particularly sometimes when it gets pretty heated in regards to over my dead body, are we going to change? He will come, I will sit down with him and show him what the issues are, and when he says, okay, you know what, just keep going, I'll make sure, I'll support, and if you get a block, you let me know. And it's very rarely that I actually need to ever call on him, because it's this empowerment in the fact that I know I've got the support of the senior people, and I'm pretty sure that at an executive level he would already be doing quite a bit in regards to pushing things forward. But I think it's very important to state that you can't do this on your own. So this is basically what we're doing. This is our big vision. So effectively, what you see on the bottom in the slide. So here we have our sort of like clinical 5 or any business critical systems that are working in a standalone fashion, clinical information systems. Here we have all the team, and that would now also include GPs, because we want to have GPs having access to a community view of our electronic patient record. And then what the development team do, and so this is where I'm very much working in, is that how do we dish up the information in regards to these systems in a useful way to these people? Because they don't want to see everything, as you know. And if you look at clinical systems or any IT systems, you actually only tend to use 5% of the capacity of these systems, because these are the things that you really need. And so what we're trying to do is optimize that to get the most out of all these things. Wherever we have gaps where, for instance, these don't do the business well, we have things like e-forms, and we can then code in open source technology ourselves. So our handover system, for instance, is the one you see in the middle. That's a front-end handover system. Basically, that's coded by us in open source Google web tool. So it's very, very sort of like usable and reusable. So as I was saying, and as I was alluding, so we had this issue about, okay, how do we create a handover system that everyone can use? And the medics will tell you it has to have all these headings, and the nurses will tell you it has to have all these headings. But when they all came together, they realized that they're all familiar with the S-bar concept. And again, I just want to check in the room that everyone sort of like is familiar with SPARK. So they all know in regards to, okay, you can use SPARK. So from a midwife's point of view, from a pediatric point of view, you know, this will all work. And so hence our headings now are related to that. So situation, background, assessment, medical and nursing recommendation. And that's how, you know, everyone is using this and they understand it because it's natural processing. Some internal collaboration examples. So the medical take, it's really, really difficult to actually represent that into the clinical system because it's obviously very, very personal and there's quite a few tricky processes that need to happen. And what I did there was I let the junior doctors actually really drive that. They really tweaked the processes and they spent a lot of time. We had a lot of iterations of how to import this into the system. But the outcome is that this whole part here, which seems very smallish, but actually that's the whole medical take. And everyone will understand in AAU or in the wards, in the medical wards, in regards to what's happened here. So there's been a referral from GP, this is the person who's done it, that's where the person's been triaged, and this is the consultant who actually was part of that decision. And as I said, it seems simple, and it is simple because it's driven by clinicians. With external organisation stakeholders, we're now starting to interface with the primary and secondary care system. So what we want to do is basically give GPs and community teams a cut-down view of our EPR, particularly looking at the discharge processing so that they can gear up when patients are coming out of hospital. It's very easy to overcomplex things, but again, that's something I've learned in the past. You know, we can really, particularly from an IT geekiness perspective, you can very easily over-engineer things. So keep things simple, and we use an agile approach, which means that every 6 weeks we do an iteration of new development, which should be like a standalone system. So you should never ever release a system that's only half developed or not complete. So what we're working on at the moment is this automatic alerting system. It's gone live last week, seems to be okay. And where we want to get to is that people will have access to our EPR. And again, I've just started on the workflow processing with GPs and practice managers, and bang, I'm hitting that wall in regards to everyone wants it their particular way. So again, it's really, really key to get that process map right, which I will do a global process map saying that, okay, 80% of your practices will work like this, the 20 you need to deal with. That's not actually what we're going to be doing. And this is how it would work. I'll just go a little bit fast in regards to, so this is the sharing of information. So these are all the people that were part of the proof of concept, looking at, okay, if we only had one way of looking at EPR from a secondary care point of view, what fields are really useful to predict and get geared up in primary care so that when the patient leaves hospital, it isn't on a Friday afternoon and the district nurse just gets a phone call saying, okay, so-and-so is coming, are you ready? This was the prototype that was developed at the time. It's just a spreadsheet. As I said, keep it very simple. What people can see here is the patient details. They can see in regards to when the discharge is looming up. They can change the parameters, and then in real time they can see what the current situation is and what the recommended care is. That will be available to everyone then. And the way that people can log into this system is we will know that they are associated with certain practices, so they will only see their patients and not all the patients in the EPR. And just to give you some metrics on that, when we started this out in regards to having a community type view of discharge processing, when we started off we had more than 160 patients who had no predicted discharge. At the end of the week we only had 40. So that's pretty impressive, because everyone knows that everyone's working together, and this is really key. So everyone is helping and driving it. And the 40 is actually quite a key number, because you can't always predict your discharge, because if you've got people in AAU and in the acute areas, you might not know what the discharge date is. That's basically it in a nutshell.